The axial part of the skeleton consists of the skull, vertebral column, and rib cage. This presentation will demonstrate the major features of the vertebral column. The functions of the vertebral column are to protect the spinal cord and to transmit weight to the ischial tuberosities in sitting and to the lower extremities and feet in standing. It gives attachment to muscles that move the trunk and head and to some of those of the upper and lower extremities. It also provides articulations for movement of ribs in respiration. The vertebral column of the fetus has a primary C-shaped curve with a posterior convexity only. By the time of birth, there is a lumbosacral convexity also. As the infant becomes able to hold up the head with neck extension, a cervical concavity develops. And with the use of the lower extremities in sitting and standing, so also does a lumbar concavity. The thoracic convexity is little changed. These curves mostly occur from modification of the discs between vertebrae. In old age, these secondary curves, which give the sinusoid shape of the adult column, tend to be lost, giving a bowed posture. Physiological, pathological, or congenital modifications may occur via changes in the vertebral bodies or discs. In lordosis, the lumbar concavity is exaggerated. For example, in late gestation, this may occur to compensate for the shift in center of gravity. However, the lumbar curve is normally greater in the female than in the male, with a greater forward tilt of the pelvis, giving the more prominent belly, buttocks, and hollow of the back. In kyphosis, there is increased thoracic convexity. This may be a postural change, as in round shoulders, or occur in the elderly. In scoliosis, there is a lateral curvature anywhere in the column. The column consists of 7 cervical, 12 thoracic or dorsal, 5 lumbar, 5 sacral, and 4 coccygeal vertebrae. The sacral segments are fused as the sacrum. So also are the coccygeal as the coccyx, although the first segment may not be fused with the rest. Hence, there are a total of 33 vertebrae with 24 discrete and 9 fused. A typical vertebra consists of an anterior rounded body with posterior arches around the neural or vertebral canal, which encloses the spinal cord with its coverings and vessels. The arches are formed by pedicles on each side, which support the posterior laminae that join in the midline. Transverse processes extend laterally from the junction of pedicles and laminae, and the arch has a spine at the junction of the laminae. Each typical vertebra has 2 superior and 2 inferior articular facets at the junction of the pedicles and laminae. These facets are usually arranged vertically, and the superior facet articulates with the inferior of the vertebra above. Thus, each typical vertebra has 7 processes for muscle attachment and articulation: 1 spine, 2 transverse processes, and 4 articular facets. The pedicles have a superior and an inferior notch, which form intervertebral foramina between adjacent vertebrae in articulation. Spinal nerves pass out through these foramina. The 1st to 7th cervical spinal nerves emerge above the corresponding vertebrae. Hence, the 1st passes between the 1st cervical vertebra and skull, the 7th above the 7th cervical vertebra, and the 8th between the 7th cervical and 1st thoracic vertebrae. All 12 thoracic and 5 lumbar spinal nerves pass out between the corresponding vertebra and the one below. For example, the 4th thoracic nerve exits between the 4th and 5th thoracic vertebrae, and the 4th lumbar nerve between the 4th and 5th lumbar vertebrae. The spatial arrangement of the sacral and coccygeal nerves will be demonstrated with these areas. Note that the intervertebral foramina are bounded above and below by the pedicles and anteriorly by the body and disc, while the articulations lie posteriorly. Osteoarthritis at the joints between bodies or articular facets with bony overgrowth, as seen here, may also affect spinal nerves, as well as reducing mobility of the column. A typical cervical vertebra has small bifid spines and a large triangular neural canal. The articular facets are relatively horizontal, with the superior facet facing up and back, and the inferior down and forward. All cervical vertebrae have a foramen transversarium that passes through the transverse process. The vertebral artery traverses these foramina from the 6th to the 1st vertebra on its path to the brain. The 1st, 2nd, and 7th cervical vertebrae are atypical. The 1st, or atlas, lacks a body. It is a ring of bone with anterior and posterior arches and lateral masses, but no spine. It has large superior facets for articulation with the occipital condyles of the skull. The anterior arch also shows a facet for articulation with the odontoid process of the 2nd cervical vertebra. Posterior to the superior facets is a groove for the vertebral artery, as this passes medially and up to the foramen magnum. The 2nd cervical vertebra, or axis, is more nearly typical, but has the odontoid process surmounting its body. This is the detached major part of the body of the atlas. Note that nodding movements, or flexion and extension, occur at the atlanto-occipital joints. And that rotation occurs at the atlantoaxial joint with the odontoid process as the axis. The 7th cervical vertebra differs from the typical only by having a long spine that is not bifid. The canal in the transverse process may be small, as it transmits the vertebral vein only. Typical thoracic vertebrae have a relatively small circular neural canal and a heart-shaped body. The superior articular facets face posteriorly, and the inferior anteriorly. So that the joints between adjacent vertebrae are in an almost vertical plane, unlike those of the cervical. The transverse processes are prominent and have facets for the tubercles of the corresponding ribs. Demifacets occur on the superior and inferior borders of the vertebral bodies. Hence, adjacent bodies form full facets. For the head of the rib, which articulates with the superior demifacet of the corresponding vertebra and the inferior facet of the one above. The 1st, 10th, 11th, and 12th thoracic vertebrae are atypical. The first has a full facet superiorly for the head of the first rib, as well as a demifacet inferiorly. The 10th, 11th, and 12th have a single full facet only on the body. The 11th and 12th have no facet on their transverse processes. Note that the spines of thoracic vertebrae are long and lie almost vertically, so that their tips are at the level of the bodies of the vertebrae below. Lumbar vertebrae have massive bodies and strong pedicles and laminae. The transverse processes have no articular facets. The spines are short and quadrangular and are directed horizontally. The neural canal is triangular and the body heart-shaped. The articular facets lie in the vertical plane with the superior facing medially and the inferior laterally. The sacrum consists of 5 fused vertebrae. It is fan-shaped in outline with upper lateral ali, or wings. It has 4 posterior and 4 anterior foramina on each side. Through these foramina pass the posterior and anterior primary rami of sacral spinal nerves 1, 2, 3, and 4. The anterior aspect of the sacrum is concave. Just below its superior limit, it bulges forward as the promontory, which forms the posterior margin of the pelvic inlet. This is part of the first segment and lies just above the first anterior foramen. It articulates above with the 5th lumbar vertebra at the lumbosacral joint, where there is a sharp lumbosacral angle. Posteriorly, the sacrum has 4 short spines, which are partially fused as the sacral crest. The laminae of the 5th and sometimes of the 4th segments do not meet in the midline and leave a sacral hiatus whose margins are the sacral cornua. The 5th sacral and the coccygeal spinal nerves exit via this hiatus. Superiorly, the ali articulate with the ilium of the pelvis at the relatively immovable sacroiliac joints. The ali abut on the posterior superior iliac spines, which are at the level of the 2nd sacral spine and middle of the sacroiliac joint. The coccyx is small and triangular. It has vertebral bodies only, with no neural canal, and articulates above with the sacrum. As mentioned before, the first segment may not be fused with the 2nd, 3rd, and 4th. Dislocation of the vertebrae without fracture is likely to occur only in the cervical region. Such dislocations with or without fracture are commonest at the fifth and sixth vertebrae. The usual cause is a fall on the head with acute flexion of the neck, as in diving, or a forward jerk of the neck, as in an automobile accident. Here the articular facets are relatively horizontal, so that the inferior facets of one vertebra can be forced anteriorly over the superior facets of the one below. The relatively large neural canal may allow the spinal cord to escape damage if the dislocation is unilateral, although the spinal nerve of that side may be nipped. In the thoracic or lumbar regions, dislocations can occur only with fracture of the articular processes, as these are relatively vertical. The usual cause is a fall from a height or a heavy weight falling on the shoulders. In the thorax, the neural canal is small, so cord damage is probable. But in the lumbar region, the canal is large, and further, the spinal cord ends at the first or second vertebra. Adjacent vertebrae also articulate by their bodies. These have discs between them, except at the atlantoaxial and sacrococcygeal joints. These discs form a quarter of the length of the column. The discs are thickest in the cervical and lumbar regions, where most movement occurs. The function of the semi-elastic discs is to act as shock absorbers and to allow for rocking movement in flexion and extension. Each disc consists of a peripheral annulus fibrosus of fibrocartilage, which is adherent to the vertebral bodies. It surrounds a gelatinous nucleus pulposus. In prolapsed or slipped disc, the relatively thin posterior annulus ruptures and allows the nucleus to protrude into the neural canal. This herniation may be unilateral and close to the intervertebral foramen, affecting the spinal nerve. If the herniation is large and central, there may be bilateral effects and compression of the spinal cord. The commonest sites of herniated discs are cervical between the fifth and sixth or sixth and seventh vertebrae, and lumbar between the fourth and fifth or fifth and sacrum, giving pain and muscle weakness. For example, if the lesion is unilateral and between lumbar vertebra 4 and 5, the roots of the fifth lumbar spinal nerve may be affected. Sensory root involvement will give pain referred to the lateral leg and radiating to the sole of the foot as sciatica. Motor root involvement will give weakened dorsiflexion at the ankle. However, if herniation is directly posterior, compression of the cauda equina may result, with paraplegia affecting both lower extremities. This concludes the demonstration of major skeletal features of the vertebral column.